morning, ladies and gentlemen. Thank you very much for inviting me to speak at the conference today. I'm Dr. Perla Eleftheriou, Haematology Consultant at University College Hospital in London in the UK. Today I'm going to speak to you about our COVID experience with patients with haemoglobinopathies in the UK. This is a presentation prepared by and presented on behalf of the COVID-19 National Haemoglobinopathy Panel and the UK CRG group. I'm going to discuss our experience in patients with inherited retinal disorders in the context of this pandemic, make reference to international data compared to our own UK data, and discuss whether morbidity and mortality due to COVID-19 is increased, and if so, whether we can identify any other risk factors. Last but not least, I'm going to make reference to the current guidance that we give to our patients in the UK based on evidence to date. Recently, there has been a reconfiguration of the clinical service provision for patients with haemoglobinopathies, and the aim of the service structure is to reduce the levels of morbidity and mortality and improve the experience of all haemoglobinopathy patients by reducing inequities and improving timely access to high-quality expert care. The diagram below describes the network and relationships between the teams. Depending on location and prevalence, the haemoglobinopathy coordinating centres are responsible for providing network support for one or more than one specialist haemoglobinopathy teams, and local haemoglobinopathy centres, all under the supervision umbrella of a national haemoglobinopathy panel. We have 14 haemoglobinopathy coordinating centres commissioned by NHS England from January 2020, 10 sickle cell disease centres, and 4 thalassemia and rare inherited anemia centres. Indeed, the pandemic has proven to be an unforeseen stress test for the National Haemoglobinopathy Panel and the regional haemoglobinopathy centres. But early on, at the start of the pandemic, the haemoglobinopathy coordinating centres got together and formed the National COVID Data Working Group, consisting of a number of haemoglobinopathy experts across the country, including myself. The aim was to provide real-time data on COVID-19 in haemoglobinopathies and rare anemias, to guide patient management in face of the emerging pandemic, but also to inform public health policies on the risk to this patient group in the absence of an effective immunization or treatment. To achieve these aims, we have built a core data set through which we collected the data regularly and used the WHO surveillance criteria for confirmed and clinically suspected cases adopted as case definitions. Anonymized data was submitted weekly by the 14 coordinating centres from April the 8th, 2020 onwards. The results were aggregated and presented regularly to the National Haemoglobinopathy Panel, and the data was shared nationally and internationally at various virtual meetings as well as through publications. This slide shows you the temporal evolution of the COVID-19 cases that we have recorded. We recorded a number of 307 patients with haemoglobinopathies with COVID-19 during this period between the 8th of April and the 5th of November 2020. As you can see, the majority of the cases were seen early on in the pandemic from April until beginning of June, beginning of July. Later on, the cases plateaued, and we can see another increasing trend towards the end of October. The first UK haemoglobinopathy case was reported on the 31st of January. Then the UK went into a national lockdown on the 23rd of March, and patients with sickle cell disease and some patients with thalassemia or rare inherited anemias were deemed to be at high risk and were advised to shield. The shielding was paused on the 1st of August, and the second lockdown was introduced on the 5th of November upon the observation that the cases were rising. In relation to the geographical distribution of the patients, you can see that pretty much the whole country was hit by the pandemic. generally, but also in relation to patients with haemoglobinopathies. But of course, you can see that from the numbers here in the table that some areas were hit a little bit more than others. The majority of the cases were seen in Southeast London and Southeast England, followed by the East London and Essex and West London areas. When we look at the patient characteristics, looking at this data, so on the left side, you can see that the majority of the patients were sickle cell patients, so this constitutes 88% of all the patients. 11% were thalassemia patients, and a very small number, 1%, were patients with rare anemias. From the patients with sickle cell disease, the majority were hemoglobin SS patients, and 18% were hemoglobin SC patients. On the right-hand side, you can see that females were slightly overrepresented than males, so 184 females, 123 males. And of course, as represented in the general population, the older patients were more than the younger ones, so 82.5% were above the age of 18 and 17.6% 18 years of age or less. 73% of the patients were positive on the real-time PCR, so proven COVID cases in our cohort, and 22% were not tested, but there were suspected cases due to the limited testing capacity in the early phase of the pandemic. Recently, we introduced the antibody testing in those who were not proven COVID cases in the past, and to date, 16% of the suspected cases which were PCR negative or not tested are antibody positive. This slide shows you the requirement for hospitalization and critical care. So 64% were admitted in the hospital during the COVID illness and 35% managed at home. In the adult cohort, 10% needed non-invasive ventilation and 6% needed mechanical ventilation. And 2 out of our 54 patients less than 19 years of age required NIV during the COVID episode, and both those patients had sickle cell disease. In relation to the transfusion requirements during the COVID episode, only 20% of the children, sickle cell children, needed a top-up transfusion, 6% needed an automated exchange. The majority, so 74%, did not need any intervention with any blood products. In the adult cohort of patients, again, the majority did not need any intervention with any form of blood transfusion. About 25%, though, slightly more than in the children cohort, needed automated exchange transfusion. In the thalassemia and rare anemia patients, again, the majority did not need an urgent therapeutic intervention with blood products. 25% needed a top-up during their COVID illness. In relation to the total cohort patient outcomes, we have thankfully recorded no deaths in the less than 19 years of age patients. The overall mortality was 5%. The inpatient mortality was 8.5%, and 7 out of 10 sickle cell patients who required mechanical ventilation sadly passed away. 10 out of 15 patients who died had single or multiple comorbidities associated with increased risk of death in COVID-19. And of note that 9 out of 10 patients were above the age of 50. If we look at the patient characteristics in these fatal COVID-19 cases, on the left-hand side, you can see that 10 of our fatal cases, which consisted of 8 sickle cell patients and 2 thalassemia patients, had 1 or more comorbidities, and the list of comorbidities is in the column in the middle. On the right-hand side, you can see that 5 out of our fatal cohort cases did not have any comorbidities, and they were all sickle cell patients. 3 of them HBSS and 2 HBSC patients. 35 patients with thalassemia and rare anemias were recorded, and 94% recovered, so the majority recovered, and 2 passed away. 3 of them are still recovering. If we look at the demography now of the second wave, which is the time period between the 1st of September and the 5th of November, which is the time point when the data analysis for this presentation was stopped, we have, during this period of time, recorded 36 new cases, all COVID PCR positive. Now, the mean age was 27 and the median 19 years of age, which is much younger than the median and the mean age groups we recorded during the first pandemic. And this really reflects what we are seeing in the general population in the UK. And if you can see on the right-hand side, the graph shows that the under 30s COVID cases were rising fast during this phase, but they're now falling. And over 30 cases, over 30s, the cases are still rising fairly quickly, which is the reason why we're expecting now more older sickle cell patients, hemoglobinopathy patients, to be for the cases of these patients to be increasing. So, risk of severe COVID-19 in sickle cell disease, as I said at the beginning. I wanted to make reference to the to international comparative data, and for this I picked the French and the American data. So September 2020 in Lancet, the French group documented 83 patients with sickle cell disease, including 17 children. 20% of them were admitted to ITU and 2% died. The outcome of this data analysis was that sickle cell disease does not appear to carry an increased mortality risk. However, and contradictory to this, the Panepinto American data published in October 2020 in the Emerging Infectious Diseases Journal, this is data through the Secure Sickle Cell Disease Registry. 178 patients with sickle cell disease recorded from 20th of March to 21st of May. 69% were hospitalized, 7% mortality outcome was that there is an increased risk for severe disease course in this cohort of patients, and high case fatality rate, which pretty much is what we have seen in the UK as well. If we now compare the COVID-19 outcome data in sickle cell disease and in the UK general population, this is analysis as of the 6th of May 2020. UK general population, about 200,000 cases of COVID-19 with nearly 15% mortality. Median age of patients admitted 73 years of age. At that point in time, patients with sickle cell disease were 166 cases, including the suspected cases, with a mortality of 7.8%, nearly 8%, with a median age of 31 years. However, adjusted for age, based on data from our National Haemoglobinopathy Registry and the Open Safely study, which was published in Nature recently, we can say that the risk of severe COVID illness is statistically significantly increased, both in the younger age group between 18 and 49 and in the older age group 50 to 79 in patients with sickle cell disease. If we look at this table in relation to the variables with survival, the association of variables with survival status in sickle cell disease patients, it is confirmed, obvious that the age is a predominant risk factor here, as opposed to the gender or the underlying sickle cell genotype. Using the COVID-19 severity classification definitions, which was published in March 2020 by Dong in Pediatrics, the Secure Sickle Cell Disease Registry which looked at COVID-19 severity and healthcare utilization in children versus adults, really comes out with the following important messages. The majority of the adults have moderate disease. The majority of the children have mild disease. 4% of the adults and 1% of the children develop critical disease. The majority of the adults needed hospitalization. The mortality was increased at 7% in adults and less than 1% in children. And 10% of the adults and 9% of the children were admitted to ITU. As a point of note, in about 30% of the patients, the pain was the predominant presenting symptom. This data was presented at ASCAT this year and was also published in the Emerging Infectious Diseases in October 2020, as I mentioned before. So what is our UK advice on COVID-19 for children and young people based on the data we have seen? So we have informed through our data the government, which then through which an updated government guidance was issued on the 4th of November. This guidance mentions that the risk of serious illness in this age group is low. The majority of the children and young people with haemoglobinopathies and inherited anemias have been removed from the NHS shielding patient list and are no longer classified as clinically extremely vulnerable patients, and that they should maintain school attendance unless following assessment by experienced clinician identifies them as clinically extremely vulnerable. For example, children who had stem cell transplantation within the last year. The guidance mentions that children should attend school normally and follow the recommendations for other children in their school, and those who live with someone with who is a clinically extremely vulnerable patient should still attend school. In relation to the younger people in further education, such as universities or colleges, they should work with their local university or education provider and be supported to maintain their education in a COVID-secured environment. The updated government guidance was issued on the 4th of November in relation to adults as well. Adults with sickle cell disease and a minority of those with thalassemia and rare inherited anemias are considered clinically extremely vulnerable. And the guidance also mentions that individual risk assessment should be undertaken to identify patients who are clinically extremely vulnerable. And the National Haemoglobinopathy Panel has developed guidance to facilitate this. These adults they're advised to work from home and limit social contact. Now, social distancing measures is applicable to the population at large and should continue to be followed. And timely treatment and monitoring of complications remain of paramount significance. To conclude, Organisation of Specialist Services for Haemoglobinopathies and Rare Anemias has facilitated rapid data collection in response to the COVID-19 pandemic, and this further informs guidance for clinicians and patients. Despite recommendations on social distancing measures, and including shielding, a significant number of haemoglobinopathy patients have indeed developed COVID-19 illness. Vulnerability to COVID-19 is increased in sickle cell disease as emerged through our data, both in severe and mild genotypes. The relatively mild course of COVID-19 in most children with sickle cell disease, thalassemia, and other inherited anemias implies that they're not clinically extremely vulnerable, and in the absence of significant complications specifically identified by their clinical team, they do not need to shield. Clinicians, though, should support the patients in assessing their individual risk and advise them accordingly. I want to end here and thank you very much to all my colleagues, the National Haemoglobinopathy Panel, all the Haemoglobinopathy Coordinating Centre leads and clinicians. Special thanks to the NIHR Imperial Biomedical Research Centre, my patients, and everyone else who's helped collecting the data and to put them on presentation. Thank you very much.